Onc Live Insights is a video editorial program produced by Onc Live.
Inherited forms of colorectal cancer only represent 5 to 7% of the patient population. Greater than 75% of colorectal cancer is sporadic. So the purpose for us to order mutation analysis is more for treatment purposes. And even though we may order a whole panel of mutations, not all those mutations are those that we can target and have a drug to utilize. And that's unfortunate. For many people, they think that once we identify the mutation, we've got a drug, we can treat you with it. And that is not the case, unfortunately.
It's very important to set expectations for the patient that although we are going to actually proceed with this genetic testing, that the results are not going to be available tomorrow or the day after, or even in a week. To set the expectation, because patients will be, and their families will be anxious about receiving the results and what they mean. An average time is 3 to 4 weeks. Sometimes it's longer depending on localizing the tissue and other complexities that go into the matter. So keep that in mind. It's very important to understand that, understandably so, patients are going to be anxious about having every result given to them today before tomorrow. So set that expectation, because that helps lowering the level of anxiety for the patient. So the results get back, and let's say we did expanded testing beyond just the typical KRAS or NRAS, or perhaps BRAF that we check for. This is where it becomes even more important to have, when you have the results, what I do typically is I have the patient come back to my clinic and we sit and just spend time to discuss the results of the genetic testing and what it means. There are certain elements of the test that could link to a certain genetic link, familial link to the cancer. And that certainly complicates the discussion beyond just the targets to now we need to rethink whether we need genetic testing for members of the family. And that's a different discussion, probably not the focus of what we want to go through today. But most of the targets, most of the mutations or alterations that we're going to find in many of these reports actually are comprehensive, and they would give you some background and some history around them. Although they can be confusing, and I think you still need to have a deeper understanding of what these mean and how they link to clinical trials first. Second, if no clinical trials are available, but some of these agents are FDA-approved agents for other indications, whether there's any relevance to colon cancer. And so when sitting with a patient, it's important, one, to explain if you found mutations other than KRAS and NRAS, what they mean. What they mean to the patient, what they mean to the treatment. Almost 90 to 99% of the times, none of these mutations are going to immediately change what you do to the patient. And that's being conservative. It's almost 100%. You're not going to change what you're doing. But you put them in perspective of the treatment continuum. Again, laying out, this is the first line we're planning on. If, God forbids, this does not work, this is our second line of attack. But we have this option, and like I said, a lot of these tests have comprehensive linking to clinical trials that may be available either in the area you live in or outside the area if the patients have the mean or the capacity. And so it's important first to always consider clinical trials, because a lot of these agents have to be tested in clinical trials to understand the meaning of these mutations. So you start preparing the patients for the possibility that we may, if the treatment does not work, we may need to move on to a clinical trial with this particular agent. It's also important to explain to the patient, if there are no clinical trials but there are agents that are FDA approved, that this could be something we may resort to at some point. But since we have many established regimens, we are going to go through the established regimens first before we get to that point.